guidelines, accountable care organizations, proactive medical management. My first question to everybody would be something that's a little bit philosophical, but do we really even need hospitals? I mean, I'm serious about that. When I came here last year, I talked about the management of congestive heart failure, COPD, and dementia, and how we created programs where these patients never saw the inside of a hospital because we aligned ourselves. We made a paradigm shift in the way we think about healthcare because it was so proactively managed. Now, there's ways to ask for more revenue, or there's ways to keep your revenue and decrease utilization. Guess what? Are the patients happier with the models we've created? The answer is absolutely. Patient satisfaction's up, cost is down, physician satisfaction's up. I go home at 5, I don't go home at 6:30 or 8 or these other ideas. We can actually do that for everybody by realigning the way we think. And this is an example of that, but I want to talk about one of the greatest utilizers of healthcare dollars and how I would argue that we are far from utilizing these dollars effectively. So it's going to be talking about nursing home care. And I would argue with you that the reason nursing home care is the way it is because of reimbursement policy and because of the cultural standards. Just the same way we tend to think of, well, the hospital's there, it just must be the right thing to do to send the patient there. We tend to think of nursing homes in the same way, and unfortunately, I'm going to provide medical evidence that we are not utilizing our nursing homes correctly. So we're going to look at the aligning payment incentives. We're going to look about paradigm shifts and the attitude of healthcare providers and the paradigm shift that should be existing for patients and families. So when you think about nursing home care, you have to think about 4 categories every time because nursing home, as a nursing home patient, well, to me, my first thought is, what type of a patient are you talking about? A skilled patient that's going to go home, a skilled patient that's going to become custodial, a custodial patient that's going to die within 6 months, about half of them do, and then the other custodial patients would last for many years. The problem we have is the different payment incentives across multiple providers. And if you look at all of the payment incentives, looking at the nursing home itself, the patient, the family, the physicians, everything we do regarding payment incentivizes overutilization. Every payment in the nursing home says do more because it doesn't categorize necessarily what do the proper level of care. And I'm not going to go through each one of these. I'm going to talk about a couple of them. In capitated models, the answer should be do the proper level of care. The worry, of course, for people when they think about capitated models is they're not going to do enough. What some people don't know is that nursing homes are regulated. And the healthcare policy, which I was talking about before, is the one that regulates the way they are capitated or where they're paid. And so they're actually looking to this guideline of how to behave. And that guideline was created in 1987 according to medical standards 25 years ago. We need to update those guidelines so they're working by standards that actually improve outcomes. People should know about Medicare and Medicaid. And I'm not going to go through this slide, but I think what's important to know is that Medicare has a dedicated tax. Everybody turns in their taxes, you get your Medicare tax. Medicaid does not. In the state of California, it's, as with every other state, it's a shared tax between the federal government and the state when it comes to nursing home care. So ironically, what has that done for states? So just like nursing homes that want to keep the patients on a higher level of care, patients want to keep and families want to keep the patient at a skilled level. Doctors and nurses want the patient in the hospital because they get paid better. States want to turf the care to the federal government because they actually don't have to pay for it. They don't have any compensation in the pay. And what have states done in those situations? They actually made Medicare maximization laws. They actually made laws to increase compensation from the federal government so that they didn't have to pay. So I want to look about the variability. You know, if you look across the country, everybody knows about the Dartmouth Atlas. This is my own medical group. Even in a controlled medical group, we have a rather significant difference, a 50% difference in the average length of stay among our nursing homes. And I would ask you, by the way, these are really good numbers compared to the rest of the country, but which of those 4 groups has the most ill nursing home patients and the one that has the subacute unit? Which one would you think that is? It's Group A. Who said that? Why?
Well, I'm saying they're trying to take care of it and not trying to jack up the cost.
Right, because they understand the management issues behind good nursing home care. And that what we found is that when people understand nursing home care better, they don't need to overutilize resources to compensate for the management of those patients. And in fact, the vast majority of patients went to to that region to be managed. Now, my organization, Sharp Sealy, happens to have, or Sharp Healthcare happens to have about 254 primary care physicians managing 100 skilled patients at any given time. But that's part of the problem, is you got so many people scattered all over, and I agree with, you better build your practices, because it really helps to organize the quality of care that you can provide to these folks. But when you have that many physicians, nobody's really that good at doing it. So you need to concentrate that among a few physicians that can provide a better focus of care. A little bit more about Medicare and Medicaid. You know, we have to deal with these many dual eligible populations. About a quarter of the expenditure of Medicare's expenditures go to dealing with dual eligible patients. 42% of Medicaid expenditures and 3/4 of Medicaid expenditures go to long-term care issues. What else do you got to know? 20% of Medicare beneficiaries discharged from the hospital go to nursing homes. For the general population, the readmission rate is about 19%. But for nursing home patients, the readmission rate is about 25%. So if you send a Medicare patient to the nursing home, they have a higher chance of being readmitted than if they went home. A third of these skilled patients will become long-term stay residents. So, and can you pick those patients out when they're admitted for skilled care? The answer is yes. Medicaid covers about 50% of nursing home expenditures, but 70% of bed days, 40% of nursing home discharges go to the hospital. And the question, of course, is why are we using the hospital for these nursing home patients? And I'm going to talk about that extensively. There's about 1.5 million of these folks. A third of adults in this country will die in a nursing home. Are we managing the concerns for the patient and family effectively and proactively so that we don't send patients to the hospital? Let me give you an example. We talk about dementia patients all the time. In other industrialized nations, they use the hospital to manage their nursing home patients at a rate of less than 1%. Less than 1%. In the United States, demented patients will see the inside of a hospital within the last 6 months of life 90% of the time. We are way on the other side of the scale. Without any medical evidence, it's in the patient's best interest, that it's cost effective or good for the healthcare industry, or that it respects the patient's wishes. Here's something people may not know. How many people know about the bed hold policies? Okay, bed hold policies are in nursing homes. They were designed this. California has a bed hold policy. So if the patient goes to the hospital, they hold the bed so it doesn't get filled up with somebody else, so they can go back to the bed they were at. Well, if you're a nursing home administrator, I want everybody to go to the hospital and just send all my staff home, because the state's going to pay me. You know, does that make any sense to anybody? Unfortunately, when we have bed hold policies, what happens? Hospital utilization goes up. On the other hand, if you pay them more, suddenly they somehow find the capacity to keep the patient there. So my conclusion to this is an economic mess. It makes no sense what we're doing. It's not in the patient's medical best interest, it's not economically responsible, and it achieves no goals for which we have been talking about this morning. Let's talk about some of the solutions. So as I talked about, one of the solutions the federal government is looking at is to federalize Medicaid. So there will be no more Medicaid in your states. It will just all be based on the government managing healthcare dollars through Medicare. They'll, you know, who knows what they'll do. They'll send a certain amount to each state to manage their patients, but it'll be Medicare dollars. Kind of a capitated state model. You'll do pay for performance. We've heard about this. ACOs, value-based purchasing. There's going to be possibly capitated Medi dual eligible capitation coming out. So I want to look at one of the models that has been presented that we could look at to improve nursing home care in this country. And what they did is called the Evercare model. I'd like to point out this were for patients who are in a nursing home for longer than 3 weeks, that for my medical group alone would have eliminated most of the skilled patients anyways. But you know what this did for this group, so I don't know whether we're looking at primarily skilled patients or custodial patients, but because we're doing so well in managing these folks. But I want to see you to see where we're coming from with these folks. So what they did is they increased reimbursement for more complicated nursing home care. They contracted via capitated models that they had. They distributed dollars and said, well, we'll give you a little bit more when the patient gets sick, but let's manage the patient in the nursing home. They had nurse practitioners. We talked about using physician extenders. They had physicians. And each physician or nurse practitioner had about 100 patients with it. I would assume that also includes custodial patients, because custodial readmissions to the hospital are rarely necessary. But if you can rapidly evaluate these patients, you can keep them in the nursing homes. And then you can lower your cost to dollars, especially if you're in a capitated model. That money goes to you. They don't use every nursing home in their region. They contract with a couple of nursing homes so they can be more efficient, rapid evaluation, staff education about end-of-life care issues. And this is to supplement care. You don't overtake the care of the facility. So what do we find in this model? That when we manage patients this way, without utilizing the hospital, by getting in there and rapidly evaluating those patients, they died less. They did better than utilizing the hospital. Remember one of the themes I told you before about the transitions model, using hospice, using palliative care? Statistically significant decreases in death, longevity increases when you use hospice and palliative care because you're actually in there proactively managing these patients. Isn't that interesting? We see the same thing among nursing home patients, that they live longer. Fewer preventable hospitalizations, that was statistically significant. Equal quality and functional status was the same as controls, patients that were using the hospital as a tool to manage late-stage disease. Secondary result, increased patient family satisfaction. The families were happier with the care. Why? Because the physicians were there. We were involved in the care of those patients. They did have a little bit more cost for mental health and podiatry. In our own medical group, we've taught our nurse practitioners to do nail care. They just go and trim the nails, which is really what podiatry comes down to, because most of these people are bedbound. 50% less skilled therapy. Half the skilled therapy. Looking at patients who had feeding tubes in a nursing home. It was hundreds of patients. And they followed these patients over years. And eventually, in this study for the 5-year period, a third of them just started to lose weight. Well, why would that be? They were getting the same nutrition, the same care. They were getting everything exactly the same. So here's the author's answer. Adequate calories and protein were provided with sample means exceeding standard means for energy, protein, and micronutrients. Still, subjects showed weight loss and severe depletion of lean and fat body mass. The study shows that despite administration of apparently adequate formula, micronutrient deficiencies and marasmic malnutrition existed in chronically ill patients. By the way, these are the patients that develop bed sores. By the way, why do we turn patients every 2 hours in the nursing home? Anybody know? It's because your arterial or capillary pressure is about 32 millimeters of mercury. But as you develop frailty and you can't absorb nutrition and you lose your subcutaneous fat and your cholesterol drops, which I'll show you about, I'll show you in a second, the pressure, the capillary pressure is going to drop. When your albumin drops, you can't heal as well. When your cholesterol drops, and we'll talk about this in a second, you get erythrocyte fragility and you get arterial degradation. And when your subcutaneous fat leaves, you don't have the protection that you used to have. Now, I had a nurse come up to me when I gave this talk to the public once. She was retired, and she was in tears. Because she said for a decade, she did everything she was asked to try to protect her patients and do everything that she could. And she just came up to me and said, thank you. Because she felt morally absolved that she had been doing everything right in the first place. We can't stop bed sores in all patients. It's going to happen if you follow standards of care, which is why we have to be careful about applying standards of care for a younger and healthier population onto this demographic. But here's the conclusion. Low-grade inflammation and neuroendocrine dysregulation are the reasons that these patients develop these problems. They're not starving and they're not receiving inadequate nutrition. I always deal with end-of-life care providers. End-of-life can be ugly. This is what it looks like when you get it right. And under that same OBRA, 1987, we penalized nursing homes that got it right. Because the more bed sores, weight loss, delirium, wasting they saw, we said, you're not doing a good job. And in fact, ironically, these nursing homes were getting patients through the entire life cycle. So we have to be very careful when we create regulations that we're not going to find out that we shot ourselves in the foot later on. These are ways to improve nutritional intake. There are things you can do. Meg-Ace, there's no evidence that Meg-Ace helps in these folks. And you do have to be careful that when you do get the tumor, they have increased risk of blood clots, diarrhea, hypocortisolism, which plays into the neuroendocrine dysregulation. Just for lack of time, I'm going to go through this quickly. Does it help to lose weight in the elderly? Well, the simple answer is this. Even intentional weight loss causes muscle mass loss, about 25%. Unless you can really get your elderly to exercise, we don't know what that ratio is. And there's still a lot we're going to learn about frailty syndrome because it's a new diagnosis. So as you lose your muscle mass to a point where you're not producing enough anti-inflammatory cytokines, that might be the signal more than the pro-inflammatory cytokines that it's time to shut down. We just don't know the answer to this yet. Which reminds me of something else. All those body mass index charts in your offices, they don't apply to this group. As a matter of fact, they don't apply to people over 65. The nadir for mortality for the elderly is 22 to 27. And there's no medical evidence under a BMI of 30 that losing weight improves mortality statistics. Where did this come from? This information, all these articles, came from an understanding of frailty. Physical inactivity is the strongest correlate of body composition. I think people saw those articles published a few months ago where they did sagittal images of CAT scan of people that had the same BMI, but one was 30% fat and the other one was 12% fat. Well, the people with high fat percentage ratios were as bad off as people who had morbid obesity. Here's exercise, inverse correlation cardiovascular health study. It's either 200 calories per day versus 200 calories per week. Now, I think some of the people in this room probably do 2,000 calories a day, and that's more than enough. But for the elderly, if we don't get these people up and moving and exercising and value those issues, that's an example of we need to start thinking as physicians, we can prognosticate with that they're not going to do as well. And the non-terminal demographics. So I went from, when I usually talk to end-of-life care providers, I talk about end-of-life, I talk pre-terminal, and then I talk about the before you become any of this. This was a study looking at calorie restriction, and then I'm going to line this all together. Calorie restriction has proven to be the most effective method to extend both median and maximal life expectancy in several mammalian species. What does it do? It decreases fat stores. Every time you eat, mitochondrial metabolism produces oxidants. Peroxycholic acid, hydrogen peroxide, nitrous oxide. How are we dealing with that right now in the American culture? Well, if you make oxides, take antioxidants. So, but what these studies showed, if we just cut down calorie restriction by about 30%, they did this in multiple mammalian species. And when I was going to UCLA about 2.5 decades ago, they were feeding animals one day and giving them water and vitamins the next day. In every animal, they lived 150% longer. I mean, 50% longer, 150% of their initial life expectancy. So what happens when you eat? You make oxides. Oxides destroy proteins. Proteins regenerate through your stem cells. When you run out of your stem cell cycles, you go into frailty, you produce cytokines. Cytokines elevate, and you create that change. That's why we have such a hard time as primary care physicians, because I can't get my patients, or some of them, to understand that I know you feel good, but you're burning through your reserve like a rocket ship. You want to keep that reserve as long as you can so that whatever's coming in life comes at a later date. So what's the conclusion? You can read all of this. There's also micronutrient deficiency associated with frailty. This is a mnemonic you can use. This is the one I prefer, which I wrote, which is you should be looking at all of these issues every time they come in, making sure they're not depressed, checking for, there may be some benefit to testosterone supplementation. I wouldn't say it for sure yet, but I think learning about what hormones eventually prove to be beneficial is good. Discussing food intake. You want to keep the patient's peripheral albumin up. You want to have a slightly higher protein diet for these folks. Resistance training, of course, we still don't want them to die of heart attacks, keep them from being isolated because they won't do what they need to do. Pain, balance issues, and yearly medication reviews. Not to add more medicines, but to stop medicines. So let's talk about prognostication. This is something I talked before about the transitions program. The transitions program integrates the lost art of evidence-based medical prognostication. We always say, well, we can't do it. I would argue that we can. We've just lost the skill. For anybody who's frail, their prognosis for mortality is about 300 to 500% higher than an age-matched control. Here's the negative feedback loop. When a patient's hospitalized for a hip fracture, they have acute phase reactance. That suppresses certain laboratory data. We see it all the time. Their cholesterol goes down, their albumin goes down, their hemoglobin goes down. What's the problem with feral patients? Well, they've already got an elevated inflammatory process that's suppressing those biomarkers, and then we put an acute event on top of that. And so they go into this vicious cycle, where they either die initially, or they go into this vicious cycle that eventually kills them. I think we talked about this last time. What's the mortality rate at 6 months for a demented patient who breaks a hip or develops a pneumonia? It's almost exactly the same, 2 different research studies. 53%, 54%. These patients start that cycle, they're at the edge of the cliff, doesn't matter whether you push them gently or push them firmly, they don't have the ability to regenerate, it starts to shut them down, and then they're done. So we looked at biomarkers. Now when you prognosticate, I'm not going to go into great detail here, you use biometric models, you use functional decline, and you use biomarkers. But I want to show you that we are missing biomarkers, particularly when I give talks to hospice and palliative care providers. We like to not draw labs. I advocate for drawing labs at the right moment and right time to validate that these patients are actually terminal. Cardiovascular health studies showed that whether a patient had a low or high hemoglobin, their mortality rates were higher. You can use biomarkers of inflammation just in steady state patients. And you have to take patients, these are studies for which the patient's maximally compensated. That increases their relative risk of death. Albumin is a tremendously strong marker. It increases the morbidity, mortality, and disability. This was a study looking at patients admitted to the hospital, 15,000 patients, age 40 or greater. If their their albumin was less than 3.5, they were 350% more likely to die. And if you're looking at patients get admitted to the hospital and trying to decide, well, I'm going to start a proactive palliative care team or a team to prognosticate or look at them more closely so that we manage them better, these are patients we should be looking at. I talked to physicians, the physician's left side, administrator's right side. What's a stronger predictor of death for a patient when they're admitted to the hospital, age or albumin? It's not age. It's albumin. The lower the patient's albumin, albumin's at 3 or lower, doesn't matter what their age, excruciatingly high. You can have an 80-year-old who's got a good albumin, and they will do better than a 40-year-old who has a low albumin. Look on the right, length of stay, readmissions. Same thing. This is a nursing home article, which I use all the time to help get my warning bells going. This was done on men, but you can look at other research articles for women. Albumin's less than 3.5. Mortality rate was 50% at 1 year. So I routinely, in my nursing home patients, am ordering quite a panel of labs that I just say order them routinely. And we'll talk about this tomorrow. But it includes albumin, hemoglobin, cholesterol, BMD. What about cholesterol? We've lost the issue of cholesterol. Why do we lose the understanding of how to use cholesterol as a prognostic marker? Because the cardiovascular health study showed that 30 to 1, we have a problem with ischemic events in this country and not hemorrhagic events. But patients with low cholesterols in other countries such as Japan or in the cardiovascular health study have markedly higher rates of hemorrhagic events. And those low cholesterols have been shown to cause erythrocyte fragility, capillary degradation, arterial degradation. So guess what? There is a downside to having too low of a cholesterol. By the way, if it's not, the patient's not terminal and they have a low cholesterol, be sure their diastolic blood pressure is down. So this was a study looking at nursing home women, showed a J-shape. That's really bad. You get low, you're in big trouble. A J-shaped relationship between mortality and serum cholesterol. They controlled for age, blood pressure, weight, history of all those issues. They excluded smokers, persons with cholesterol medications, patients with liver disease, if they were not just custodial compensated patients in the nursing home. And what did they find? That for patients with low cholesterol, there was a 520% greater risk of dying at that's 4.4 millimoles. That translates into 155 milligrams per deciliter. You know, our proactive diabetic program would be elated if they had that number. I personally think every nursing home patient in this country who's custodial should not be on a statin. They should not have medicines to lower their cholesterol of any kind, because it just puts them at risk of these hemorrhagic events, plus bed sores. 900% increased risk of bed sores. And historically, there's been an increased risk of cancer, but that's, by the time they have cancer, it's irrelevant. And compare that to the nadir, which was 270 milligrams per deciliter of cholesterol. That's the nadir for mortality. Now, if you had a high cholesterol, they call that 339, your risk of death was 180%. So, what about men? Different study. Cholesterol is less than 150, death rate was 63% at 14 months versus 9% of the cholesterol was above 150. Another study, 10-fold greater risk of dying if they had low cholesterols. Really low cholesterols, 89, 1,000% higher risk of dying. Twofold risk at a high cholesterols. The nadir in this study for both was 181 milligrams per deciliter. Low albumin hemoglobins and low BMI have a 400% risk. Those are all prognostic markers. This is what in hospice we call the trifecta. But you don't have to order hospice on all of your nursing home patients. I don't. But if you want to know what's coming, I always talk about the reactive model of healthcare. We wait till these patients have bad outcomes. But when you order routine laboratories so that they don't use the hospital as a tool to manage disease, and you proactively talk to the families, patients with all three being low have an 84% mortality rate at 1 year. Would you use this data? Could you create a model of care that would proactively manage these patients so that we gave them better comfort and better care? You can use this for hospital patients, patients who come in with a good cholesterol. Next day they have a low cholesterol, their mortality is statistically elevated. And for patients, that's 2 in a row. Got the study backwards. 2 low cholesterols in a row. High cholesterol, low cholesterol, not quite as statistically significant, but p-value of 0.08. So, just in conclusion, that was a rapid-fire discussion. I left out a lot of information. I hope I haven't gone over my time. We just have to recognize that our models of care are opportunities to provide better care. There's tremendous opportunity provided we use what emergent medical evidence is telling us is a better way to manage these folks, to be cost-effective in these areas, and to stop, especially if we're proactive, but stop using the hospital as a tool to manage these patients after they've decompensated. So, thank you very much. Any questions?
Non-clinician here, so I apologize. 2 quick questions.
Sure.
The last 2 slides of the cholesterol studies,
Yeah.
23 to 31 years old, why does it take so long for this to now get into, let's do the